Today, I'm really delighted to have now Emeritus Professor Eric Legis with us, who is one of the pioneers, I would say, in terms of care and research in NF. And this masterclass was supposed to be held in conjunction with Ellen Denaye, who apologizes for not being here today, but Eric will be covering all the subjects on his own. Just a little detail regarding the Q&A. Eric will be giving the lecture now, and you can put your questions in the Q&A box or in the chat box, and I will be moderating the Q&A after the lecture. Unfortunately, it won't be possible for you to interact directly with Eric, but I'll be in the middle. And with that said, thank you, Eric, for joining us today to talk about the rarity in the rarity, which is rare tumors in NF1. And the floor is yours.
Hello, everybody. My name is Erik Legis, as you can see here, and I'm an emeritus professor at the Center for Human Genetics in the University of Leuven. Today, I want to go with you over a number of rather rare tumors in individuals with neurofibromatosis type 1. And here on this slide, I give a list of the tumors that I will deal with. So first, we start with the dysembryoplastic neuroepithelial tumor of the brain, then we'll go over the bone tumors, the giant cell lesions of the jaw, and the non-ossifying fibromas. Then we will continue with the abdominal tumors to go to the glomus tumors of the digits, and then say a couple of words about cutaneous malignant melanoma. So the first one is the dysembryoplastic neuroepithelial tumor. This is a rare tumor, but if we go to this review about epilepsy and NF1, it is shown here that from 621 patients with NF1 and epilepsy, a total of 9 turned out to have a dysembryoplastic neuroepithelial tumor. If you do the opposite and you look at all the individuals with a dysembryoplastic neuroepithelial tumor, you will find a large percentage of individuals who in fact have neurofibromatosis type 1. So this is an example of one of my patients here, where you see in the temporal region a growing mass here and there. So it was in the region of the hippocampus, and it was associated with a therapy-resistant epilepsy. So the only thing that could be done was to do surgery. So many individuals with NF1 who have intractable epilepsy and go to surgery have this dysembryoplastic neuroepithelial tumor. This is a recent analysis of the genome of dysembryoplastic neuroepithelial tumors, and this consists of all kinds of different origins, not only NF1, but as you can see here from this list of tumors, there were 3 of the tumors that showed an NF1 mutation, and in one of those 3 it was a germline mutation. Also variants in FGF receptor 1, FGF receptor 2, NF1, PDGF receptor alpha, BRAF are all reported, and points towards the RAS MAP kinase system as being important in the pathogenesis of these disorders. Also, PIK3CA is important, so also the PI3 kinase pathway is involved, and also PTPN11 here in one case. Giant cell granuloma of the jaw. Now we come into the bone tumors. These are giant cell lesions. It's not really a granuloma, and it are bone lesions with giant cells, but it is not the giant cell that is the initiating cell. It are the stromal cells within these giant cell lesions that are the initiating cells. There are benign lesions, They usually appear in the second to third decade, more frequently in the mandible compared to the maxilla, and they can be solitary or multiple. Here I show you a case that I have seen myself, and this case had both a maxillary lesion and a mandibulary lesion. Here you can see the maxillary lesion as an expansive growing tumor here in the upper jaw, and here you better see the lesion in the lower jaw that is expansively growing and is destroying the bone in the region. Here we could, it was removed, the lesion was removed and was filled with bone grafts. We could culture the cells and analyze the NF1 mutation, and we found the second hit. We found the same second hit in the upper and the lower jaw. The patient also has on the same side more abnormalities of the skin, of the brain, of the hair, and so on. So here we hypothesize that it is an early second hit, an early hit in the embryonic development of the cranial neural crest that is responsible for all these lesions. But it shows you that these are the stromal cells in these lesions have the second hit in the NF1 gene, not the giant cells. They are secondarily recruited. And this is another patient that we studied together with the group from Hamburg with Vic Mauder and Reinhard Friedrich. And it's a multilocular mandibular giant cell granuloma, but in fact it's not a granuloma, and the giant cell is not the primary initiating cell, but also here they were able to send us some tissue, and in that tissue we were able to find a second hit in the NF1 gene, but in the stromal cells, not in the giant cells. Then the next bone tumor is the non-ossifying fibroma. These are also benign bone lesions, usually in the second decade of life. More frequently in the lower extremities and around the knees. They're usually asymptomatic, and you pick them up if you do an X-ray because of unequal leg length or whatever. They usually regress spontaneously after puberty, but sometimes they are associated with a fracture after a minor trauma. And it is the combination of non-ossifying fibromas in combination with café au lait spots and other features of neurofibromatosis type 1 has been reported in the literature as Yaffe-Campanacci syndrome. But in fact, if you look very careful, most of these cases have a proven NF1 mutation. Not all of them, but most of them have a proven NF1 mutation. As you can see here in the left image, you see the expansile growing non-ossifying fibroma with a little pathological fracture due to a minor trauma. Usually these cysts undergo curettage, are filled with bone grafts, and then are stabilized here with an external with a fixator, but that's not always necessary. And here you see afterwards that it healed completely. So most of the time they are asymptomatic, they don't need any treatment, and they regress spontaneously. And only in very rare cases you need to do surgery if there is a pathological fracture due to a minor trauma, but this is the exception. And abdominal tumors, here I refer to a nice review paper from 2012, where they list all the gastrointestinal manifestations of neurofibromatosis type 1. And of course, you have the neurogenic neoplasms. You can have the neoplasms from the interstitial cells of Cajal, and these are clinically relevant gastrointestinal stromal tumors or like incidental very small gastrointestinal stromal tumors, which can be seen when a part of the intestine is removed. It can be seen under the microscope or directly by eye, but are very small. And then under the microscope, it is frequently associated with hyperplasia of the interstitial cells of Cajal. And then you have the neuroendocrine tumors, which are less frequent in NF1 compared to the gastrointestinal stromal tumors. So first we will deal with the gastrointestinal stromal tumors. They frequently affect the small bowel, which is in contrary to the gastrointestinal stromal tumors you see in the general non-NF1 populations. They usually affect the stomach, but in NF1 it's usually the small bowel, so the duodenum, ileum, jejunum. These are c-KIT positive stromal spindle-shaped tumors. So the cells are spindle-shaped. At least 5% of NF1 individuals will show this tumor sometime during their life. And as potential symptoms, it could be an abdominal mass, it could be pain, or bleeding with blood-stained stools or vomiting of blood. And it could be really catastrophic. So it could be very severe bleeding with people who end up in the emergency room because of an hemorrhagic shock, because they have lost so much blood. And then, of course, if it's a chronic problem, the fatigue can be fatigue due to anemia. It is recommended to remove the symptomatic tumors surgically, or if they are detected incidentally, to remove them if they are larger than 2 centimeters in diameter. So here you see a large gastrointestinal stromal tumor. They do not grow in the epithelium, but they grow in the wall of the intestine. So they are mesenchymal tumors in the wall of the intestine, not in the epithelial layer, but they grow into the lumen. The epithelium is removed by all kinds of food that passes by, and it can lead to a massive bleeding. And on the right side, you see the spindle-shaped cells. And if you stain them with an antibody against KIT, you will see here in the middle image that this tumor, which is under the epithelium, stains all the cells. They stain with KIT. And if you look at the epithelium itself here on the right side, you see a couple of cells that stain with the antibody against c-KIT, and these are the mast cells that are normally present in the epithelial layer of the intestine. And that serves as a control for your staining. More than 15 years ago, we have been working on these gastrointestinal stromal tumors because at that moment it became clear that they were more frequent in individuals with NF1 than in the general population. And together with the group of Ludwien Messiaen, and here in Leuven, the group of Maria Dembiec-Richter, we were able to analyze in 3 different individuals with NF1 a total of 7 gastrointestinal stromal tumors. Those that arise in non-NF1 individuals, so the sporadic non-NF1 associated gastrointestinal tumors, they frequently have a mutation in the KIT receptor itself, a dominant activating mutation in this tyrosine kinase receptor, which activates the receptor and then results in an activation of the MAP kinase pathway, the ACSTAT pathway, and the PI3 kinase pathway. So it's most of the time a KIT mutation or a PDGF receptor alpha. KIT and PDGF receptor alpha, they belong to the same group of tyrosine kinase membrane receptors and are very close and very similar to each other. As you can see here in table 1, we did not find any of these 2 mutations in the 7 tumors that we analyzed, but in every tumor, except for 1 year, a second hit in the NF1 gene was identified, showing that loss of the the wild type NF1 allele is the cause of the growth of these tumors. And also it was shown that by looking at the NF1 gene and the second hit, that they really belong to the tumor spectrum of individuals with NF1. In table 3, it is shown that many of these tumors, they contain copy number gains and losses very similar to what you see in the sporadic tumors. So aside from the NF1 loss of the wild type copy, we also need to have some copy number gains and losses, like 1p loss is very frequent, that then stimulates the cells to grow further. In general, these tumors have a better prognosis than in sporadic cases, but they have the potential to metastasize. When we go to the latest recommendations for surveillance and treatment of tumors in individuals with NF1, it is strongly recommended to resect lesions that are larger than 2 centimeters or lesions that are symptomatic. Here is a case of my patients, where you can see a whole body MRI with the blue arrow pointing towards this lesion here in the abdomen, which you can also see on the 2 axial images in the middle and on the right side. And this was a gastrointestinal stromal tumor. It was in the wall of the duodenum, and it was removed by surgery. If you detect them incidentally, they can usually be removed by laparoscopic surgery with very, very few morbidity for the individual. This is a study from Japan from a couple of years ago, from 2016, where they looked at 95 adult NF1 patients, and they were screened by CT scan, and they found a gastrointestinal stromal tumor in 6 of them, meaning that in their series, about 6.3% of the individuals in a cross-sectional study turned out to have a gastrointestinal stromal tumor. This is another study from Finland about intestinal tumors in NF1, with a special reference to fatal gastrointestinal stromal tumors. And this is from the group of Juha Peltonen. They have done a population study, and they have a finished care register for healthcare with 1,410 NF1 individuals. And in these, they found that the highest hazard rate was observed for tumors in the small intestine. And when they looked at the NF1 death certificates, just demonstrated that it was the primary cause in 7 individuals. So also here in Finland, they had several patients that died because of a gastrointestinal stromal tumor, which can be picked up when it's asymptomatic by a whole body MRI. At this moment, it is not recommended in the guidelines from the ERN, the European Reference Network GenTourist, to actively screen for it. But if you see that in Finland, and also we experienced an individual who died because of massive bleeding by a gastrointestinal stromal tumor, you might consider doing this. This is another study where they looked at abdominal tumors in individuals with neurofibromatosis type 1. And they ended up with 43 adult NF1 patients that were followed at the dermatological department of the Department of Dermatology of that hospital. And in 6 individuals, they detected 8 abdominal tumors. So which is quite high if you refer to the 43 NF1 adult patients. When we look more into detail, from these 6 individuals, there were 4 who in fact had a gastrointestinal stromal tumor, so that's a little less than 10%. 3 had a pheochromocytoma, and there was 1 who also had a periampullary somatostatin producing tumor, which is quite rare. Now this brings us to the neuroendocrine tumors, with at the first place the pheochromocytoma, and at the second place the gastrointestinal carcinoid tumors. And within the carcinoid tumors, the gastrointestinal neuroendocrine tumors, the periampullary somatostatin producing endocrine tumor, the somatostatinoma is the most frequent in NF1. Gastrinomas and insulinomas are really not frequent in NF1. In the general population, periampullary somatostatin producing endocrine tumors are seen in less than 1% of those individuals who have a functional neuroendocrine neoplasia of the gastrointestinal system. It is estimated that only 1 per 40 million individuals per year in a general population will develop such a somatostatinoma. And there is a strong association with NF1. If you go through the series of somatostatinoma, you will see that many of them are associated with neurofibromatosis type 1. However, the true incidence in NF1 individuals is not known yet. But I also have 1 or 2 individuals during my career that were diagnosed with this kind of tumor, which is quite rare. And it can metastasize, just as the gastrointestinal stromal tumors can metastasize. It's also possible for the periampullary somatostatin producing endocrine tumors. The combination of a pheochromocytoma and a gastrointestinal carcinoid tumor is also seen in multiple endocrine neoplasia and in multiple Lindau syndrome. It is not limited to neurofibromatosis type 1. So this is an immunohistochemistry on a tumor that was removed from the duodenum, and it showed the strong staining for somatostatin. Now, pheochromocytomas are more frequent in NF1. It's a tumor of the medulla of the adrenal glands. And you see here on the right side, you see the kidney. And above the kidney, where the arrow points, there is a round tumor, which was a pheochromocytoma. It is associated with an increased secretion of catecholamines, which can provoke symptoms, but in my experience, most secreting pheochromocytomas that I have diagnosed in adults with NF1 were not associated with symptoms. But after removal of the tumor, most of the patients said that they felt much better, that after removal of the tumor, they were again feeling like years and years ago, and they were more calm, they were not that nervous, and they had less tension. But when I asked up front, they would never say that they had any symptoms like headache, palpitations, or sweating, which are the typical symptoms associated with NF1. It is extremely rare in patients with NF1. And you don't want to wait until they have all these symptoms before you diagnose it. Hypertension is very difficult because I never found it associated. And maybe you have to do 24-hour registrations or so, but in my experience, hypertension is not associated. So most of these that I have diagnosed had no symptoms and were incidental findings on MRI. They all had increased excretion of catecholamines and metanephrines in the urine. And it is recommended to screen for pheochromocytomas in pregnancy because during the process of labor, due to the increased abdominal pressure, the adrenal gland is really squeezed like a lemon, and all the catecholamines are released in the blood during labor, which can be dangerous. It can be treated by surgical resection. And as you can see here, also routine biochemical screening is not recommended, except for women who are contemplating pregnancy or who are already pregnant. It is also advocated to screen for a pheochromocytoma in case a person needs an abdominal surgery, because then if they somehow touch the adrenal gland, it might provoke severe cardiovascular complications. A cortical sparing adrenalectomy should be preferred if possible due to the risk of a metachronous contralateral adrenal tumor. And one of my patients had a bilateral adrenalectomy because it was not possible to have the cortical sparing adrenalectomy, and then they of course need a complete substitution for corticosteroids. This is a study from France, from Patrick Combemal, who looked at 156 adult patients, and they diagnosed 12 pheochromocytoma, of which 6 were secreting. So that's about a little less than 4%. And this is over a period of 1 year. So this is a cross-sectional study of 156 patients. So this is quite high to identify virtually 4% of individuals with a pheochromocytoma in a cross-sectional study. When we look at our retrospective study of 276 adults and adolescents that we screened with whole body MRI, and also by history taking, clinical examination, and so on, with a median follow-up of nearly 5 years, we identified 11 secretory pheochromocytomas, which is also around nearly 4%, which is very close to the study of Patrick Combemal in Paris, or in France, sorry. We also identified in this group 6 GISTs, so 4 that were detected by the whole body MRI. 1 was retrospectively diagnosed on a whole body MRI that was missed at the time the whole body MRI was taken, and 1 was detected after the whole body MRI 3 years later, and then we went back to the whole body MRI and it was not seen on that whole body MRI. So this is 2.2% in our series of gastrointestinal stromal tumors. That you can see, if you detect ANUPs, so the atypical neurofibromas in our series at an average age of 30, the pheochromocytomas at an average age of 39, and the GIST at an average age of 53. So with increasing age, you have a higher frequency, first of pheochromocytoma, and secondly of gastrointestinal stromal tumors. So I think it depends a lot on the age distribution in your patient population, how much pheochromocytomas and gastrointestinal stromal tumors that you will detect. Then, of course, we go to one of my favorite topics, which is the glomus tumor of the digits. The glomus organ is an organ that is localized in the distal phalanx of the digits. It is a neuromyoarterial structure here, and it's in fact a anastomosis between an arteriole and a venule. And it's a thermoregulatory organ that can shunt the blood and prevent it from flowing through the fingertips when it's cold in the winter, and then it opens in the summer when it's hot. Of course, the shunt closes and the blood is forced to flow through the fingertips so that it can help cool down the body. If you have a glomus tumor of the digits, we usually see that it causes pain which is provoked sometimes by cold, so it's a cold intolerance, and it's a very localized tenderness. So if you go with a very small instrument and you probe the fingertip, there is only like one specific point that provokes pain. So it's a localized tenderness, and it's very cold sensitive. I had one of my patients who worked in a restaurant, and when he had to go and get some additional food into the walk-in fridge, he would first take a bucket, fill it up with warm water or hot water, and put it outside of the walk-in fridge. And as soon as he came out from the walk-in fridge with all his cold food, he would put his hand with the glomus tumor immediately into the hot water to relieve the pain. Because then, of course, the blood is shunted away from the glomus tumor and is not forced to flow through the glomus tumor, which can be extremely painful. Usually, it is this triad of pain, localized tenderness, and cold intolerance, and you don't see anything at all at the tip of the finger, which makes that it takes sometimes many years before a diagnosis is made, because there is nothing to see at the fingertip. It's only painful. No x-rays, no ultrasonography, no MRI shows anything, and the patient has a lot of pain, and then they start looking at the whole nerve going from the neck to the arm and the hand. There is nothing to see. So it takes sometimes many years before a diagnosis is made. In sporadic non-NF1 patients, a glomus tumor of the digit is a solitary tumor. But in NF1 individuals, we see that it is frequently multifocal, affecting more than one finger at the same time or over time in the same individual. This is a picture where the localized tenderness was located in the first individual that we diagnosed. And this is a publication from 2002 with our hand surgeon, Professor de Smet. And here you can see this glomus-like organ with all the glomus cells. These are, in fact, smooth muscle containing cells here. With different lacunae where you can have where the blood flows. Then, of course, once we had seen one case, and I knew what the symptomatology was, I started to diagnose more and more cases, which gave the opportunity for Hilde Brems, who was then a PhD student in my lab, to study these tumors that were prepared by Luc de Smet, or a hand surgeon. They were removed under local anesthesia, and she could show that the smooth muscle actin positive cells contain the second hit in the NF1 gene, not the Swan cells that you can grow from that lesion. So it's not a Swan cell tumor, but this is a it's kind of a fibroblast-like cell that has a lot of smooth muscle, alpha smooth muscle actin. Then there is this nice summary by Doug Stewart on the diagnosis, management, and complication of glomus tumors of the digits from 2010, which is still a very nice review paper that describes all the different things. If you wait long enough, sometimes you see this red or bluish hue at the position where you have the localized tenderness. Here you can actually see the tumor because of it is associated with the swelling with a blue hue and also a dystrophy of the nail. So it's sitting in the nail bed, pushes on the nail, and is extremely painful. Here you also can have the impression that you see some little swelling here at this position. And here also it was associated with the splitting of the nail. But of course here, this is not as far as it was there. So this is at the beginning, and this is at a very advanced stage. And in fact, there should not be any NF1 patient who presents in this stage anymore. Now that we know that it exists, that it is part of the NF1 tumor spectrum, and that is relatively easy to recognize and to treat under local anesthesia. You do not need to show it on MRI if you have a good hand surgeon, because it is relatively simple to diagnose clinically. We never do in our center MRI of the hand. The hand surgeon just clinically examines the patient and then organizes surgical intervention under local anesthesia and always manages to remove a glomus tumor. This is a summary. You can see here, this was a combination of patients that we had seen in Hamburg, Germany, in Leuven, and in NIH, and most are females. This is from the previously reported number of cases. Most are females. And as you can see here, it's the fourth finger is the third and the fourth fingers are the ones that are mostly affected. And several of them had multifocal tumors, while it is not seen in a general population where you have the same kind of tumor, but then it's an isolated case. As you can see here, years of symptoms before diagnosis, it can be really very long before a diagnosis is made, because it's not very well known that it is associated with neurofibromatosis type 1. So when I see an adult patient, I will always ask for pain in the fingertips, and during clinical examination, I examine the fingertips and I put a little pressure on the fingertips as a way of trying to provoke symptoms and find the glomus tumors. And every year there are 1, 2, or 3 individuals with such a tumor who have surgery. Then I want to say a little bit about malignant melanoma. So the first publication on this topic was again a publication from the French group with Pierre Wolkenstein. And they looked at a melanoma incidence in patients with NF1. And they say, well, we do think there is an increased melanoma incidence, but we are not completely sure because our series is relatively small. And they found more females and a higher thickness than expected, and a frequent association with a second neoplasia. But they were not completely sure if this was real or not. Then there is a publication here of the group of Finland, where they did a population study, is the group of Juha and Sirkku Peltonen. And when you look at melanoma of the skin, which is also indexed, and you see there is, like, they expected 1.9 and they observed 3, so they did not have sufficient power to find an increased number because the numbers are too small. Now, a more recent study from last year in JAMA Dermatology, they did a retrospective cohort study, and they included 4,122 patients with NF1. of which about a little bit more than half were women. And they found an odds ratio of 2.27 for melanoma of the skin. So they suggested that there might be an increased risk of melanoma, although it is small. So it was a large national database which was used with rare genetic disorders and skin cancers. It's limited to patients with the commercial insurance that were available. So there were a number of potential biases, and also the fact that NF1 patients may seen more frequently by dermatologists might increase the chances of them being diagnosed with skin cancer. And the relative risk is relatively small, and the absolute risk is not that high, and they said it might not be clinically meaningful, and it's probably not relevant to change screening recommendations at this moment. And then here, this is another very recent from this year, also from the United States, where they again looked at studies that have been published. They looked at 53 papers with 188 NF1 patients, of which 82 had melanoma. And they compared it with the general population, and they ended up with odds of 2.55. So there are now recently two studies. One is a retrospective cohort studies. The other one is a study from everything that has been reported in the literature. And they both suggest that there might be a slightly increased risk for melanoma in NF1 individuals. I don't think at this moment that it is warranted to change any screening. We just have to pay attention to it. It is known that in sporadic melanoma there is a high frequency of somatic mutations in the melanoma cells itself, in the NF1 gene. It's the third most frequently mutated gene in sporadic melanoma. It's also associated with desmoplastic melanoma, so with a specific form of melanoma. But as is frequently seen in individuals with a germline mutation in the NF1 gene, there might be a slightly increased risk for melanoma, and it's not that severe as you would expect based on the fact that it is so frequent, seen as a somatic mutation in melanoma. So by this, we have come at the end of my presentation. I want to thank the people from my research group here and all the other external collaborators, and I want to thank you for your attention. Marco, you're still muted.
Yes, thank you, and apologies. Thank you, Eric, for this very thorough overview of the rare tumors in NF1. We have questions coming up in the chat box. The first one is from Amadeo Azizi. He is wondering if you've ever seen children with glomus tumors of the fingers.
Yes, I've seen a child with a glomus tumor of the little finger, and it was so painful that when the child came in, as a child with NF1 came into my office, she would help her one hand in the other, close to her body, with a face that said to me, "You're not going to touch my little finger." So it was so painful. It was also enlarged, but in children it is relatively rare. So I've seen it in one child, but I don't think it is relevant to systematically screen young children for a potential, or children in general, for a potential glomus tumor. We also have in our series a case from Hamburg who had the glomus tumor of a toe, but that is rather exceptional.
Well, thank you. There's a very interesting question coming from Ignacio Blanco, who wonders if you've ever seen a familial aggregation of uncommon tumors, and if you think a surveillance of these families should be done.
I have not seen it for gastrointestinal stromal tumors, but I have seen a clustering of pheochromocytomas in one of the families that I'm following, with I think 4 relatives from the same family affected with the pheochromocytoma. And in this specific family, their NF1 germline pathogenic variant is a missense variant. So there might be a genotype-phenotype correlation in this specific family, or it is possible that specific variants predispose to pheochromocytoma. We know that this is the case in von Hippel-Lindau syndrome, where missense variants have a much higher risk for pheochromocytoma than those with a truncating variant. At this moment, we don't know if this is the case for pheochromocytomas, but that's my personal experience. I have not found anything in the literature on this. So I would be very interested if someone has more data on this. It's a very interesting question.
We have a question coming from a patient, which I'm going to give to you. Is it common to have multiple plexiform tumors over the body? The patient laments that she had one in her right pinky, causing issues with cold and pain numbers, pins and needles.
Yes, that is, if it's in the pink and if it's at the end, say in the tip of the little finger, and if it's sensitive to cold, then it should be, the patient should contact a hand surgeon, because the chances are quite high that this is potentially a glomus tumor. On the other hand, it's also common to see multiple plexiform tumors over the body. That is not exceptional. We see that more often. Yeah.
A question again from, thank you, Eric. A question again from Gianluca Piccolo regarding non-ossifying fibromas. Do you confirm there's no need for further surveillance after occasional detection during adolescence? Should we tell patients that are at a higher risk of fracture and therefore pay more attention during sports?
No, because the risk of fracture is very low. I have seen it maybe 2 times in 35 years or so. So I don't think there is a need to actively screen for this. One has to bear in mind that if there is this fracture due to minor trauma and an X-ray is taken, that you might diagnose at that moment a non-ossifying fibroma, which should then be removed by curettage, and the cavity should be filled with bone grafts, and that cures the problem. I don't think we have to screen for it, first of all, and secondly, when you see it incidentally, I don't think we have to refrain the children from sports. I don't think, because in most cases it will never provoke any problem.
But thank you for clarifying this. I see no other questions in the chat, so I may come up with a question myself. And I wondered, when you were talking about the giant cell granulomas, I wondered what the effect on the quality of life for the patients typically is, and whether what kind of therapy there is for this kind of tumors.
Yeah. So the giant cell granulomas of the jaw. We also have, I didn't show the picture, but you can have the central giant cell granuloma of the maxilla. So in the upper jaw, in the central region, you can also have this granuloma. If it's small, it doesn't give any problems, but those that become symptomatic grow expansively, and they eat the bone away. It's a mass, and there, of course, it might be associated with pathological fractures, and it might affect the quality of life. If it's relatively small, then you can remove the tumor surgically by curettage and filling it up with bone ends. But if it's very large and you don't think you can remove everything, then it becomes problematic, and it can affect the quality of life. Sometimes these individuals are treated with products that inhibit the osteoclasts, like calcitonin or other products. If you can inhibit the osteoclasts, these are the multinuclear giant cells, or in fact osteoclasts. They are stimulated by the aberrant stromal cells, and it's the stromal cells that have the second hit. And if you can contain the activity or reduce the activity of these giant cells, of these osteoclasts, then you get again some bone formation. But it's not a simple way of treating.
Thank you. There is another question from Casey Libman, who apologizes because he missed the initial part of the talk, but he was wondering whether there's a, how common the gastrointestinal tract tumors, how common are those that cause acute anemia?
Yes, so these are the gastrointestinal stromal tumors. We from the study of Patrick Combemal in France, and from our study, which are more cross-sectional studies in adults, we believe it's in a cross-sectional study, it's about 4%. But if you follow people over time, the risk to ever develop such a tumor before the age of 70 is probably higher, and is somewhere between 5 and 10%. So in fact, it is not so rare, but it is not very well known. Now, most of these tumors are asymptomatic, but when they grow and they become larger than 2 centimeters, you can have two problems. They can cause acute blood loss, so acute hemorrhage, but it can also metastasize. So we have in our series one individual who was detected without any symptoms, but incidentally by a whole body MRI. And afterwards, after removal of the tumor, it turned out a couple of years later that she already had a metastasis in the liver, which was then treated afterwards. So they're not very malignant, and in general, the prognosis is much better than isolated gastrointestinal stromal tumors in non-NF1 individuals. So for the same size of tumor, for the same cellularity, the same number of mitosis, so for the same situation, the prognosis is better if you have it as an NF1 individual than when you have it in a non-NF1 individual. What we frequently see in NF1 individuals is that they have multiple of these tumors, and it's not necessary to remove all of them, but only those that are 2 centimeters or bigger.
Thank you. I actually have another question myself, which is rather strange, but still I'm going to do it. I wondered if it's ever happened to you to actually make an NF1 diagnosis after a finding of one of these rare tumors. that a patient presents with one of these rare tumors.
Yes, sometimes it's because of the gastrointestinal bleeding that we come to a diagnosis. But most of the time their NF1 was known, because most of these things happen in adults. I have not been dealing with the juvenile myelomonocytic leukemia, because this is not a tumor, this is a leukemia. And also in children, you have a slightly increased risk of developing a rhabdomyosarcoma. But then in these young children, when these leukemias or solid tumors develop, they might not have had yet the diagnosis of neurofibromatosis type 1. And there, of course, you more frequently are confronted with the fact that due to a tumor, the diagnosis of NF1 is made. But that's, in my experience, relatively rare and exceptional in adults with NF1.
Thank you. I see no other questions in the chat box or in the Q&A box, and our time is almost up. So I wondered if there was anything from the conversations that we've had that you'd like to point out to the audience, any new thing?
No.
Before. Well, I thank you very much, Legis, on behalf of all the patients for this lecture, and the audience for their very lively participation. This masterclass is now over. We have 2 more programs already and lined up in November and December, and we're in the process of defining new dates for the new year. So do continue to check our website, and you will be notified by email if you're on our lists. And I wish everyone a very nice evening. Goodbye.
Bye.